you very much to everybody that's here. You know, it's when I think of Wellspring and I think of Astellas and I think of the wonderful gentlemen that have come out tonight, I feel very privileged to be here. As you can well hear, and which has been said, I am from South Africa, and it's wonderful to be in Canada. I'm now Canadian. I've been here since 2004. Excuse me. I'm actually a medical oncologist. And about 6 or 7 years ago, I really changed my track from being a medical oncologist with an interest in palliative care to a palliative care physician with an interest in oncology. It gave me more of an idea of wholeness, of being able to look at patients and their families. You know, as an oncologist, I treated tumors. And as a supportive and palliative care physician, I treat patients with tumors. So I think that is really the difference between the two specialties. And in addition, the modern idea of palliative care is called the bow tie model. And it's to start supportive and palliative care early on in the course of the disease. And if the person goes on and becomes a survivor, that's still part of palliative care. And if the person goes on and the disease is not curable, and eventually they succumb to the disease, that's also part of palliative care. So palliative care, one of the components is end-of-life care, but the other component is definitely survivorship. All our patients, when we see them, are evaluated from a symptom point of view with what we call the ESAS, which you'll see a little bit later, and a distress thermometer, so that we are really and truly not just treating cancers. We're treating people that have got the cancer. And cancer-related fatigue is one of those really distressing symptoms that patients feel and that complain about, and not many people know what it is about. And so tonight I thought of presenting this particular deck of slides that was also presented to some of the healthcare professionals. And you may say, well, you patients, but you're very much the leader of the team, because it's all centered against patient-reported outcomes. It's patients that are feeling and expressing what they're feeling, and it's the physicians and nurses and any healthcare professional that need to respond to that. So I'm going to present this to you, and then it will give you an insight as well into how the healthcare professionals view fatigue. And so next time you speak to your healthcare professional, you may have a little bit more insight on what you need to say and how you need to say it and how you need to describe it. Because there's many people, you have to pull them along the road that in order to get to where you need to get to. This deck of slides was not put together completely by myself. I've put some of my own slides in it, but thanks to Astellas and a group of professionals, which were physiotherapists, physicians, psychologists, social workers. They've put this together, which I think is very comprehensive and will allow us to understand what we need to understand. Okay, let's just make sure that we get the slides moving now. These are the steering committee of the people that put the slides together. And that's just my disclosure. I do some work for Tetra Pharmaceuticals, which are very, very busy at the moment organizing a randomized controlled trial for vaporized cannabis for patients with advanced cancer. So my objectives tonight are first of all to describe what is the prevalence and the impact of cancer-related fatigue. How does one assess this particular fatigue? Because it's not just being tired. How do we treat it? And how do we refer for exercise, for psychosocial help, for sleep, for spiritual advice and nutritional-based interventions that can help reduce the cancer-related fatigue? And who can help? Who can really help? I believe everybody in the cancer team including the patients and their families, should be able to help. So this is to how to present the problems to the particular team so that they know what is needed of them and explain to them how you need help. It is about communication. As I keep on saying, not many people understand it as well as what the people that are experiencing it understand it. So 1 in 2 Canadians will develop cancer at some stage in their lifetime. The number of cases in Canada is expected to rise. And as we know that treatment and care continue to improve, and the survival rates for most types of cancer are therefore improving. And there will be a substantial increase in the number of patients who are cancer survivors. And the people have to learn to cope with significant long-term effects of cancer and the cancer-related treatments, and cancer-related fatigue is just one of those. So when I say what is fatigue, and I ask 10 people, I may get completely different results. Some may say it's tiredness, weariness, weakness, no energy, drained, pooped, wiped out, exhaustion. And I'm sure all of you at some stage have identified with some of these descriptions. The actual definition of cancer-related fatigue is a distressing, persistent, so it really causes distress. It's persistent, it's subjective. Nobody can really understand that feeling that the person is feeling. It's tiredness or exhaustion, and it's related to cancer or the cancer treatment. And it's not really proportional to recent activity. You know, one can go on a long run and feel quite tired out, and it interferes with the usual functioning. And I think that is the point, that we're talking of quality of life. We want to feel that we're functioning. Of course, realize that functioning in a physical domain, in a spiritual domain, in a vocational domain, you know, to be a father is a vocation. If you cannot be a grandfather and look after your grandchildren because you're too tired, that is a problem with a vocation. So it's subjective, it's definitely tired, it's exhaustion, and it's related to cancer. It's longer lasting than normal fatigue, and it's not relieved by rest. There's definitely an amount of intellect with poor memory and concentration. Where did I leave the keys? Did I forget to switch the stove off? Have I put gas in the car? And it's this loss of enjoyment of previous activities that one used to enjoy doing. Watching movies, doing some gardening, going out to speak to friends. Some may say that's depression, and I think depression does come into it, but it's not only depression. And I'm going to just show you some results of we started a palliative rehabilitation program in Ottawa at the Elizabeth Bruyere Hospital. And it was an 8-week program where patients were accepted to the program, had exercise program for 8 weeks, nutritional intervention, an interview with a social worker, with an occupational therapist, with a physiotherapist, and individual programs were designed. And then we looked at the different domains of fatigue. And as you can well see, there's not just one domain. Sorry, let me just try and get rid of that if I can. There's general fatigue, there's physical fatigue, there's mental fatigue, activity, and motivation. And with our program, we were really able to show an improvement in most of those domains. So fatigue can be treated, and that is important. I can't get this to move on its own. Sorry, not getting it to move on its own. I'll have to push the slides here. Sorry, guys. So, it's common, as you can see, between almost 60% and 100% of patients having cancer or cancer treatment will at some stage develop this fatigue. For many, it's present at the diagnosis, and as treatment goes on, many people develop it. It may be an early symptom of malignant disease in almost 40% of patients. And then virtually all patients that are treated with some form of therapy, radiation or chemo, will experience fatigue. And unfortunately, it can continue for months or even years after the completion of treatment. This is one of the ways that we've assessed it using the Edmonton Symptom Assessment Scale, and this looks at the majority of symptoms that patients with, this is advanced cancer, but it's with patients with cancer as well. And you can see, I always call it PD and F, pain, depression, and fatigue. Those are the most common symptoms, but these can be treated, and they can be treated effectively without pharmacological interventions. You can see tiredness decreased in our program significantly, depression decreased, anxiety decreased, and nausea and vomiting also did. So a proper structured program, as I know Wellspring, certainly in Shinkuzi has, can address fatigue. So there is hope. What is the impact of this cancer-related fatigue on patients, on the informal caregivers, and on the healthcare system? So for patients, need I tell you that your activities of daily life and your quality of life are certainly affected by fatigue. Other symptoms are also enhanced. People that have fatigue usually are more pain, more anxiety, more depression. And so much so that it's been shown that patients that experience fatigue have less compliance with a particular treatment. Just don't feel like going to get my treatment today. Not really interested in it anymore. For the caregivers, burnout, exhaustion. One may call it nagging. It's also a frustration with the healthcare professionals. Why is the doctor or the nurse not doing anything to help my husband? Why don't they understand what he's telling them? That it's not just the tiredness. Yes, he wishes he could sleep, but even when he sleeps, he wakes up tired. And he's not eating well. And he's nauseous. And he's irritable. And he's sad. This, related to cancer-related fatigue, is all in one. It's very difficult to separate them. And for the healthcare system, certainly increased costs, more visits, and then side effect management is definitely increased if fatigue is not addressed. So what are the causes of this fatigue? And as you can see, when you see a diagram with multiple bubbles, you'll know that there's not just one cause. And I think I'll just take you a little bit through this, because I think then you'll probably understand a lot more as well. We see there's the cancer, the disease process itself. As the cancer grows, it secretes a number of different cytokines and hormones. Some of them have ghastly names like cadaverine, or cachexin, or bombazine, or putrescine. These have an effect on the brain, and in a way, they override any feelings of wellness that one can feel because of these particular cytokines. Physical symptoms can be very tiring. If a person has got pain, very tired. If they're nauseous, it's very tiring. If there's anxiety and depression, that adds to the fatigue. Then, of course, people don't sleep. And up to 35% of patients with cancer do not sleep. And it's those patients that have not sleeping that have worse and more intense symptoms. And one doesn't know, is it because the symptoms are worse and not properly treated that the fatigue is worse? Or is it that the sleep is not sleeping and therefore that makes the symptoms worse? When you're tired, you don't have any exercise, you're just too tired to go for a walk. You don't feel like eating very much, so you don't get any energy in, which then, of course, compounds the fatigue. You may have anemia, which we know there's a certain oxygen is carried in the blood. You need a certain amount of hemoglobin, which is one of the proteins within the blood vessels that carries the oxygen. Once it's oxygenated in the lung, it takes that, the heart pumps the blood to the different muscle groups, so that one gets a little bit of energy, because you need oxygen in order to get energy. Medications, those pain and the analgesics, the hypnotics, and many, many other more treatments can all contribute to the development of cancer-related fatigue. So what is the role? And this is where I'll say this, I've presented this to everybody. But I think we're all part of the same team, so it doesn't just help to present it to healthcare professionals. So what is the role? And this is a team that we developed at McGill and then took it to Ottawa as well. And it's an interdisciplinary team. And you'll see right, and the biggest part of it is the patient and the caregiver are part of that team. And surrounding them are the physiotherapist, the occupational therapist, the dietitian, the doctor, the nurse, the psychologist, the social worker. So it's all one big team. You're not going to get the right answer from each one of them. You'll get different answers from each one of the members of the team and different approaches and different interventions. And they are all important. It's not a one size fits all. So I often say to physicians or to nurses or to OTs, do they often screen for cancer-related fatigue? And I unfortunately can say that majority of them say C and D. They don't really. So these are the kind of questions, and these are the things that you as patients should be saying to your healthcare providers. These are the guideline recommendations. At the initial diagnosis, doctor, I am tired. And then periodically through the treatment, doctor, I'm still tired. This is where I need help. And if they say, well, how bad is your fatigue? Try to use some kind of objective numerical scale so that they write down in their notes, today it was a 6. Maybe next time it's an 8 or it's a 3. But unless we say how much it is, today I know and God knows. And if I'm not here tomorrow, God only knows. So it is important to try and get an objective measurement and to think what is reproducible. And that's why we use the Edmonton Symptom Assessment Scale, which is used on all patients that have some kind of cancer. It's been validated, and some of the more chronic diseases like cardiac failure or renal failure or respiratory failure. And it does give a patient-reported outcome, because this is what the patient is telling us. As William Osler said, listen to the patient. He's telling you the diagnosis. So unless you tell the physician the diagnosis and how bad it is, he may not know to ask that, and he may not know how to follow up on it. So there's mild fatigue, there's moderate fatigue, and there's severe fatigue. And it is important to mention these. The other tool that we use is the distress thermometer and the Canadian problem checklist, which was developed here in Canada. And that gives a visual idea of your distress. How bad are you? How distressed do you feel? Is it a 0 to a 10? And then there are various domains. There's a physical domain, there's a spiritual domain, there's a financial domain, there's an emotional domain. And these all need to be properly assessed in order to see where the problem is and what kind of intervention can be given. And specifically, I'm talking about fatigue, because that's why we're here tonight. But fatigue, as we see, in 60 to 100% of people with cancer. So it's not a small problem, it's a majority problem. So if one has, and you've assessed yourself as being moderately or severely fatigued, let's then look more specifically at the onset. What makes it better? What makes it worse? Is there anything else that could be contributing it? Is there insomnia or depression? What is your level of function? are you deconditioned? And how are you interacting with those loved ones around you? One of the things that I will recommend is that even if you don't feel hungry at meal times, sit with your family. Let them know that you're there. And if you don't feel like eating, and that may happen, that your wife may say, Bill, I've made your favorite curry for tonight, and you say, I just don't feel like it. And tomorrow she said, I've made your favorite omelette and I don't feel like it. That continues. Just rather persist than get up and say, well, you know what, I'm just going to sit in the kitchen because I'm not contributing much. So family have to learn to the new normal, and we have to help them to better understand. And that's why I keep on telling you, this is about communication. We also have to assess if there's any other problems that are focused. And I'm talking about disease history. We need to think of, is there anemia? Is there hypothyroidism? Which medications are one taking? Is there any recreational drug use? Is there polypharmacy? Some people are on 10, 15 different medications that may interact with one another. What type of cancer? What's the stage of the cancer? Is there recurrence? Is this tiredness due to recurrence? Or is it just due to the treatment? Or is it that you finish the treatment and you're in the recovery phase? And I'm specifically using the recovery phase for the physical part. When we move from the recovery phase to the healing phase, then the whole person gets healed, not just the body. And of course, one should always have a thorough, proper physical examination. All too often, and specifically it's been manifested now with the COVID, that this physical examination, where the physician will listen to your lungs, will feel in your neck, feel under your arms, feel in your groins, your liver, listen to the lungs, listen to your heart, see if you've got any peripheral edema, is far too overlooked. And I do realize that I came from the British system where clinical examination is a very key to medicine, but it's not just the physical examination. I firmly believe it's very much more reassuring. It also allows touch, which can be therapeutic. And it's taking a blood pressure, it's showing that there's an interest. And most of all, when one's working against a symptom, one wants to feel that you've got a good team around you. And that's what hope is. Hope doesn't necessarily imply complete cure. Hope implies that you've got the best team around you working together with you to obtain the best outcome. So the physical examination and the blood work and looking at what the disease is and seeing specifically what type of fatigue this person has is all part of what is necessary. Now, we've been speaking a little bit about the different dimensions, and I've kind of mentioned some of it, the emotional fatigue with low mood, the motivation. You know, one may have been a woodworker, you may have been a philatelist. That seems to be one of the dying pastimes of our generation. You may have collected whatever it was, stamps or coins or dolls or, you know, miniatures. My wife is a miniaturist. So those interests, if you don't have them anymore, they do help to relieve fatigue. For sure they do. Sorry, I just need to get rid of this again. What was it? Sorry, guys. Don't seem to be able to get rid of it. Amazing how some things work and then they don't work. I don't know. Let's see if I move on, if it moves on. Then I will always ask, how comfortable is a person in managing fatigue in the practice? I think this is also very important. Is one moderately comfortable, very comfortable, slightly comfortable, or not comfortable? And I must unfortunately say the majority of people are telling me they're not comfortable. Right, here we go again. Sorry, we've got to get this back here. So, looking at an individualized approach, taking on what we looked at, the causes, the disease status, the stage of the cancer treatment, the age, and the patient preferences. Treating fatigue, treating people, treating patients is individualized. And I think this is the bulk of what I want to talk about, is this what we as healthcare professionals can do and what everybody as patients can do. And these are based on the assessments, the preferences, and there's very good data that all of these interventions do help to relieve that fatigue. The physical activity and exercise, psychosocial, psychological strategies, sleep, spiritual practices, and nutrition. So how can physical activity help? We know that physical activity in the broader term encompasses all forms of muscular movement and not just exercise, but this should result in an increase in energy expenditure over the resting levels. So one needs to work hard enough to burn up energy, but then you'll say, but I'm too tired. And that's exactly that. Once one starts working those muscles, one gets them conditioned, moving, the blood flows better, they communicate better, they contract better. So exercise is a form of physical activity that is performed on a repeated basis over an extended period with the objective of improving physiological function of the muscles. And we know that it's now part of routine cancer care. This is an article that we wrote in The Lancet 2 years ago, saying, this is a Canadian group, showing clearly that exercise does help. And how does it help? There's the direct and indirect effects: muscular strength, fitness, inflammatory response. We've all been hearing a lot about the inflammatory response and the cytokine storm that goes along with COVID, where the immune response is almost putting fuel onto the flames. As that immune response gets better, people get more sick. So the more inflammation was had, in the old days we thought that was what was good. Having high fevers when you had an infection was what you needed. But in fact, it may be the fuel that feeds the flames. So dampening the inflammatory response, doing the exercise lessens the insulin resistance. Because if we think about what insulin does, insulin causes glucose to go from the blood into the cells. If there's an insulin resistance, the glucose does not go into the cells, with the result that the muscles get broken down in order to produce glucose. Indirectly, the psychological and the social effects of exercise cannot be underestimated. And we all know if you have a good workout, you will sleep better, and you'll probably have a better appetite as well. And here we can see that although it's maybe counterintuitive to have exercise for cancer-related fatigue, in fact, many patients always were told, take it easy and rest. But we now know that physical activity is safe, it maintains, it improves health-related fitness during treatments, and it also improves quality of life. And I think this graph block shows it more favorable. All the interventions, the pharmacological interventions doing the least. Exercise and psychological making quite a difference. Psychological on its own, exercise on its own. So putting all these things together, the psychological and the exercise interventions certainly do improve outcomes of cancer-related fatigue. Now, for most patients with cancer, any type of physical activity, we're talking about walking, yoga, will relate and cause a decrease in that fatigue intensity. Some are better. We generally tell our patients half an hour of walking 5 days a week for aerobic is great. But that's walking. Start at 1 minute a day, go to 2, go to 3, go to 4 until you work yourself up. That will be good. Start slowly. Now, I just want to show you some of those physical measures just after a bit of exercise, and these are all patients with metastatic cancer. The Bergwood balance, so that improved. The reach forward, improved. The grip strength, improved, maybe not significantly. And the timed up and go, where you ask a patient to stand up from a chair, walk to the door and walk back, and you measure how long that takes. After 8 weeks of treatments of this physical intervention, all those physical measures improved. It does work. Now I would like to show you something else, what such a program can do, and this is the MD Anderson symptom inventory. So you'd say to the patient, how does the cancer or the treatment thereof affect your general activity, your mood, your work, your relationships with others, your walking, and your enjoyment? T1 was the time one, T2 was 8 weeks later. Just look at that. This is from a nutritional exercise program with some psychosocial intervention. All our patients, and these are patients with metastatic cancer, improved. How much more so for patients that have had the cancer and there is no more cancer, just the after effects of the cancer. These are the guidelines. 150 minutes per week, or 75 minutes per week, or a combination of moderate and vigorous. The resistance training is also important. Take a dumbbell, take a barbell, do some press-ups, do some sit-ups, improving the muscular strength, the body composition, more muscle, less fatigue, better quality of life. And those are the different examples. And you have got the slides, you'll be able to see what they mean. Now, I'm very pleased to say, and I know this for a fact, that Wellspring offer these kind of exercises according to these guidelines. So to be associated with like-minded people who do care makes a big difference. So how can social and psychological strategies help to reduce the fatigue? Once again, we see general fatigue, fatigue intensity, fatigue distress, and fatigue interference, all effectively treated with self-care, coping strategies, making sure you have got self-efficacies. You're able to do what you want to do, not what somebody else wants you to do. That you play an active role in managing your symptoms. Empowering. Empower is the new word. One doesn't want to feel like a victim. One wants to feel like a victor. So exercising, you can do it. Nobody can do that for you. Eating well, nobody can do for you. The way you think and your attitude, only you can do. Nobody can do that for you. These are important. And these are what the psychological interventions are aimed at. And this is really just what cognitive behavioral therapy is all about. One has negative thoughts, makes one upset. There's unhealthy behaviors, unhelpful behaviors. You know, I'm a victim. I didn't deserve this. I'm punished. I'm sad. I'm going to die. We're all going to die. It depends on where. So we are what we think in a large way, and they all related. This fatigue-specific CBT or cognitive behavioral therapy aims to change unhelpful thoughts, beliefs, and attitudes, and helps patients overcome that catastrophizing and demoting thoughts of daily life. Those panic attacks that just wear one out. So all information, and these are basic information to include when educating patients, and I'm giving them to you again because this is what is expected of healthcare professionals, is to say what the difference between normal and cancer-related fatigue is, what are the causes, what patterns does one see, and most important for all of us is to keep a log or a diary to monitor the fatigue levels, because very often you'll say, I'm just not getting better. And if you have a look how you felt 2 weeks ago, 3 weeks ago, 4 weeks ago, you will see that there is an improvement. And if one's getting worse, it's necessary to tell your healthcare team, because maybe something's just not right. Maybe too much chemo, maybe I'm anemic, maybe too much medication, maybe I'm not eating right. Just keep your healthcare professional as part of the team. It is important. Sleep. How can one optimize sleep? So this is the difference between fatigue and sleepiness. The lack of energy to do activities like exercise or even going to work. This feeling that your eyes are closing, and I hope I can't see you, but I hope I'm not putting you to sleep. Having these heavy eyes, watery eyes, just feeling sleep. Difficult sometimes to differentiate. And having a look once again how that cognitive behavioral therapy can actually improve sleep. We see that on the graph, that there are different components, which is including the stimulus control, sleep restriction, cognitive restructuring, and sleep hygiene, which we'll speak a little bit in the next slide. By modifying behaviors, by making sure that you sleep in your bedroom and not in the lounge in front of the television, by making sure that you go to bed at the right time, that you have a big, thick book that if you're keeping awake, that you're doing something, that you're not watching the television, but that you're trying to get your mind active. And if it doesn't get active, you'll fall asleep. So take those distracting devices out of the bedroom and put books in instead of televisions. It's one of the things that I do say to patients. Restrict when you're going to sleep. And if you find yourself falling asleep at the wrong time, ask somebody to wake you up. Also make sure that you're not drinking too much caffeine before you go to sleep. And sometimes alcohol can make you fall asleep, but it's a disrupted sleep. So try and control the amount and moderate. Moderate's the game to life, not excessive, but rather moderate. Spiritual practices. Not many people get a spiritual history done. And there is a recognized spiritual history that is standard. It's called the FICA. Do you have any faith? Is it important in your life? Do you have a community that help you, that pray together? And how do you want this addressed in everything that we as healthcare professionals can do to improve your quality of life? So it's once again that mindfulness, the meditation, the praying, the fact that you're working in a community and that you believe in something that can help you to feel better. And once again, we see that addressing the spiritual needs can help lower distress and fatigue scores. And here they define spirituality as a sense of peace and of purpose and connection to others and beliefs about the meaning of life. What is this all about? Why am I here? You know, I tell patients as well that we know the exercise helps. We know the nutrition helps. But if you can wake up and say, what difference can I make in someone else's life? That they're going to say, I'm looking forward to that person coming to visit me. I'm looking forward to his phone call. Or I'm looking forward to him reading to me. These are important, that one finds reason over and above what you're doing for your family. Because that more or less comes naturally. But for somebody else, this is important. So these are some of the practices that can enhance the well-being and likely are beneficial. Self-reflection, meditation, compassion, which is the Dalai Lama has always said it's compassion. All religions really promote compassion, having community and prayer. Growing body of evidence that says that the mind-body therapies, Qigong, yoga, mindfulness-based meditation, does improve mood and overall quality of life. And there we have it, the mindful-based stress reduction. It's in a structured group program. It's designed to cultivate the increasing level of mindfulness and there's definitely increasing efficacy in improving cancer-related fatigue. Please note that many of these classes are often available through many psychosocial departments and, once again, through Wellspring. Nutrition. You know, is it just good enough if I drink 3 bottles of Ensure a day? Well, I don't think so. I think one needs to have proper food. And it can be difficult. But there's always some windows throughout the day. Some people prefer it in the morning, some in the evening. If you're only having 1 good meal a day, make sure that you really going to make use of that meal. Are there any specific tastes that are better for you? Any specific smells? That's what is, I would recommend that even if you just have 1 interview with a dietitian to give you an idea of what is available. If you're constipated, if you have diarrhea, if you have sores in your mouth, if you're just generally tired and don't want to eat, what are strategies? So nutritional-based interventions definitely help. And we saw this with our program as well, that over 8 weeks we had a statistically significant improvement in the nutritional screening of the patients that went through the program. And once again, I'm talking about screening. Look at these kind of things. This is what our patients all undergo. The patient nutritional and functional assessment. It takes 2 minutes while you're waiting for the doctor. Has my weight increased? Has it decreased? Do I have any symptoms? Nausea, constipation, sores in your mouth, smells, problems of feeling full? How's my food intake changed? And what's my general activity like? This gives the physician a good idea of what's going on. And hands down, the biggest predictor of quality of life is weight loss. The more weight you lose, the worse your quality of life. That's been shown over and over again. So any intervention is aimed at one not losing weight. And these are the interventions. You need protein, meat, fish, eggs, milk, cheese. I recommend to my patients 3 to 4 eggs a day if they can. That puts protein in, and protein builds muscle. And like any good machine, if you put the right fuel in and then you run that machine, then it works. So get the food in and start your exercise. And these are some of the evidences that it makes a difference to cancer-related fatigue. Not very big studies, but certainly low protein intake was associated with high levels. Cancer-related fatigue, people that had mild or no cancer-related fatigue consumed more fish, whole grains, vegetables, and others, and using omega-3s also seemed to improve cancer-related fatigue. And all of these general nutritional guidelines on the Canadian guideline advice. Diet low in saturated fats, red meats, and alcohol. And then what about the pharmacological interventions? You know, it does seem to be easier to take a tablet than to do exercise. It's also easier to take a tablet than to eat the right food. It's also easier to take a tablet to go to sleep, but they're not as effective. And there's proof of that too. They may help, but they're definitely not as effective. So there's really insufficient evidence at this time that any of these medications, whether they allopathic or naturopathic, that they improve the outcome of patients with fatigue. And this is what I think I'm really trying to show you, is one needs the patient personalized action plan. This is your passport. This is what you are about. This is where you need to keep your diary and keep your log. And Astellas have really put this together in order to develop the personalized action plans. And my recommendation is that each one of us should have one of these, whether you have cancer, whether you don't. But if you're fatigued and look through this, you'll get a good idea of what needs to be done. Because it's so important, once again, speaking of that team, that the patients and the families are at the center and the healthcare professionals are all around. So we've got the decision aid, we've got the management guide with general tips, strategies, and a list of additional resources that all come with this. And once again, this is a question that I'm asking the healthcare professionals, and I'm asking you as patients, as survivors, from that side, to look at what you want your healthcare professional to ask. Are they discussing cancer-related fatigue interventions with you or not? So just quickly to summarize, one should be screened and assessed for fatigue. Any reversible causes such as anemia, nutritional problems, psychosocial problems should be looked at and addressed wherever possible because the cause of the fatigue is multidimensional, multifactorial. And person A may have fatigue related to lack of sleep, person B may have anxiety, person C may not be eating well. And it needs to be regularly assessed and followed up. So thinking of motivational and behavioral changes, how does one do that? And patients need to be aware of the problem. And they have to understand, people have to understand that there is something that can be done and done successfully. There is hope, there is light at the end of the tunnel. Tell your physicians your goals, your preferences. Speak openly about goals of care, advanced care directives. Many people are frightened already to speak about such things, but knowing that that has been sorted out, if and one day when you will need them, that it's there, and that as one gets ill, that you bring families together and you don't push them apart. Well, dad wanted this or dad wanted this. No, he wanted that. No, he wanted this. Try and get clarity in where one's own life is going. Work collaboratively with your healthcare professionals. Start small and review and review and review and see how one is improving. It does help. And I think at this stage, I'm not going to go further more about the communication tips because this really is to physicians. And I'm going to end over here and I'm going to say it's almost an hour that I've been chatting. If there are any questions, I'm very happy to take them. So if we could perhaps unmute one another, that would help.